Our next presentation will be a video presentation by Marina Broomfield from McGill University entitled Do As I Say, Not As I Do, The Evidence Mismatch in Pediatric Surgical Practice.
Good morning, everyone. My name is Marina Broomfield, and I am a student at McGill University. It is a pleasure to be here today and talk to you about the evidence mismatch in pediatric surgical practice. Do As I Say, Not As I Do is a study which I've had the pleasure to work on along with the help of my supervisors, Dr. Robert Baird, Dr. Dan Pinero, Elena Wadagno, and Sina Agabani. Evidence-based medicine, according to Sharon et al., proposes that clinical decisions be made on the basis of trustworthy evidence deployed by clinicians who use their clinical judgment and take into account the patient's values and circumstances. Common elective outpatient pediatric surgical procedures, such as dermoids, epigastric hernias, hydrocele, and umbilical hernias, are managed and operated on daily. Yet, the indications and timing of their operative management, and even whether surgery is necessary at all, still remain a point of controversy, creating a gap in the evidence used for treatment. These conditions have a very low morbidity rate, but generate significant parental anxiety, which surgeons can alleviate either through a quick surgical intervention or through careful discussion and shared decision-making. Our objective here was to explore the mismatch between existing evidence-based management recommendations and actual practice patterns for these 4 common outpatient pediatric surgical procedures. Using the Crozier Rapid Review Group recommendations, along with librarian oversight, we extracted data concerning surgical indications, timing of surgery, justifications presented for the chosen management, empiric evidence cited, and ultimate patient outcome. Initial screening was conducted by 2 independent reviewers using Ryan software, where titles and abstract were assessed, followed by a second review, where the full article of the selected references was analyzed, with a third reviewer resolving any discrepancies. Our rapid review included 914 papers, along with an additional search of articles published in recent years, resulting in a total of 831 papers, out of which we included 52 studies in our analysis. The following table summarizes our results for each of the 4 conditions and highlights the significant variations in practice along with their justifications. As you can see, the evidence backing up various practice choices is generally weak and often antiquated. Due to the time limitation, in the following slides, I will highlight the variations observed in 2 out of these 4 conditions. Since the natural history of hydrocele is poorly documented beyond the age of 2 years old, it is unclear whether hydrocele that are still present or that have recently developed beyond that age should be observed with the expectation of spontaneous resolution. Despite strong evidence that isolated hydrocele have no effect on later fertility, several studies continue to use higher temperature environments in the testes in the presence of a hydrocele as a justification for earlier repair. All studies agreed that surgical intervention is required for hydrocele with an associated inguinal hernia and possibly those extremely large in size within the first year of age. Umbilical hernias are also associated with minimal or no risk of complications and may also appear to resolve beyond the usual suggested age of repair of 5 years old. Despite this, formal guidelines demonstrating the benefit of deferring treatment well after the age of 4 to 5 years old are conspicuously missing. Although umbilical hernia repair is a minor procedure with minimum tissue disturbance, the dangers associated with any surgery are particularly substantial in young children. Confounding variables such as patient's ethnicity still remain a subject of debate. In conclusion, the available literature on several common elective outpatient pediatric surgical procedures reveals wide variations in indications and criteria for surgical intervention. Individual practice choices are justified based on vague risks of complications, frequently using weak and/or obsolete evidence and common wisdom rather than high-quality empiric evidence. Updated evidence-based practice guidelines for common elective pediatric surgical procedures are needed, as well as clinical practice actually adhering to these standards. In the absence of better evidence, we can always fall back on patient-centered discussion and shared decision-making. Thank you everyone for listening. If you have any questions, please feel free to ask them through the Whova app.